everyone, and welcome to this EONS symposium on SARS-CoV-2 and its impact on cancer nursing. In this session, we'll hear from 3 expert nurses for the range of backgrounds who currently work in cancer center management, research, and active clinical care. The presentations examine the impact of COVID practice on their working lives, institutions, and patient care with very practical and concrete examples from Belgium, Germany, Switzerland, and the UK, highlighting the breadth and the impact of cancer nurses across Europe. Our first presentation comes from Matt Fowler, who will present his very personal experiences of cancer nursing in a COVID pandemic. Thank you, Matt. And now I'd like to move on to our second speaker, Mr. Johan de Munter. Mr. Johan is the EONS president-elect and graduated as a cancer nurse in 2001 and worked for several years in general hospitals until qualifying with postgraduate qualifications in pain management, cancer care, and teenage and young adult care. A high flyer, Mr. de Munter was rapidly elected to the national boards of the Flemish Hematology Society and the Flemish Society for Radiology and Oncology Nurses. In 2017, he was elected to the EONS board and is on track to become the EONS president in 2021. So over to you, Johan.
Hello, everyone. Thank you, Emma, for the brief introduction. So COVID tackled us all, I think, around the world, and also in our hospital. We have to change our services to get very well cancer care for our patients. Therefore, we did some observation of the period between March and May and what we achieved as cancer nurses and cancer nurse-led services. So I have nothing to declare. First of all, I want to give you an insight in the Belgian pandemic numbers, and these numbers are daily updated by Science Sano, which is a Belgian research facility institution on public and animal health. In total, we had around 85,000 cases at this moment in Belgium, and unfortunately we have almost 10,000 people that are passed away by COVID. They're high numbers. And we had a total admission of 19,000 people in our hospitals. At the pinnacle of this pandemic, we had 629 hospitalizations a day in Belgium. In our hospital at this point, currently patients in the hospitals are 221. That's a big difference. So it's declining. We have still patients on ICU, and it's around 60 patients. Luckily for us in our hospital at this moment, we have 1 patient with COVID in admission and ward. He is lying on ICU. So it's very going well in our hospital at this moment. At the highlight of the pandemic, we had 5 units dedicated to COVID patients, and including 2 intensive care units that were available for COVID-19 patients with the necessary care and supportive care for their patients and caregivers. So what's also an interesting number is the reproduction number, I think, to keep in mind. At this moment, we are around 0.97. That means that at this moment, a COVID-19 patient with an infection or that has tested positively infected 1 other patient at this moment. So I hope in the future we can decline this number to 0. So let me introduce a little bit where I work. During the pandemic, I was still working as a nurse consultant for hematology and stem cell transplantation. I work at University Cancer Center, and which is an umbrella department which focus on innovative and high quality multidisciplinary treatment and care for people with cancer. The center pays special attention to support and surrounding of the patient and the caregivers. In addition, the Cancer Care Center has a coordinating role and support to streamline the care together with the hospital oncology and hematology departments, together with the physicians and the administrating nurses. So in the cancer center, we employ cancer nurse consultant, clinical nurse specialists, oncodietitians, psychologists, social workers, data managers, project coordinators that are assigned to the different cancer care services in the hospital next to the physician and cancer nurses on this department. But it's true that also our cancer nurse services were changed by the COVID-19 pandemic. And if I can give you some key dates in Belgium. So in end of February, the Belgian government gave some guidelines to the hospital, and it was very clear that something was coming our way that we couldn't imagine at this point. So the hospital decided already to create a hospital task group that was monitoring for 7 days and 7 and 24 hours the whole situation. A couple of days later, the 10th of March, we had the first registered death by COVID-19. And at 40 March, the hospital decided that visitors are not longer allowed and non-urgent consultations and interventions are postponed. We in the hospital didn't choose to postpone or to cancel everything because care has to go on, because else we got in problem after the pandemic. So at 18th of March in Belgium, the government, there was a decree that urgent measures to limit the spread of coronavirus. And at that point, homework and staying at home was mandatory if possible. So there were some challenges for cancer nurse-led services in the lockdown. First of all, none of us had experiences a pandemic before, so we didn't know what's going to happen or what was coming our way. There was no time to falling back on routines because this was something new. There was not an option to do this. So it was at this moment we had to continuously monitoring and analyzing and being very flexible and adapting to services. So the hospital installed a task group that was monitoring the situation. In that case, luckily, the task group ordered the necessary protective equipment, for example, at front. So during the pandemic, healthcare workers never experienced any shortages at these protective materials. So the overall attitude was a proactive one in order to prevent situations that get out of control. So everybody was in need of a proactive approach, also if it comes to cancer nurse-led services, because we provide as cancer nurse consultants and clinical nurse specialists, we provide additional services next to the administrating cancer nurses. So what we keep in mind as we maintaining delivering high quality cancer care, because that's very important that there is a continuously care for patients. But there is still some important challenge to tackle during a pandemic. First of all, this maintaining. We were asking, will this work and how we will do this? As people with cancer identified as a risk group, it's clear that we needed to strengthen infection prevention and empower patients and caregivers to deal with all measures to prevent COVID-19 infection, especially because they are a risk group and they're immunocompromised, for example. So therefore, we need to develop strategies and use appropriate tools to contact patients and deliver them appropriate information. At this moment, we were not familiar with telephone support. Patients contacted us, but it was mainly the patient that contacted our services than the service contacting the patients. We had some little experience with, for example, with people that are on oral anti-cancer drugs, that we start having some experiencing by calling them proactively, but that was not enough to implement all these cancer nurse services on telephone triage, for example. At the same time, it's also important to continue to provide psychosocial care as patients and caregivers or still have to cope with their cancer diagnoses and treatment into follow-up. So combining all these factors, it's obvious that patients, caregivers, and even healthcare providers are dealing with stress and increased anxiety during this pandemic. Also, a care gap is defined as a discrepancy between recommended best practices and care that's actually provided. from different research, we know that on-time screening, dose on time during treatment, and comprehensive timely follow-up are crucial to tackle the cancer burden. Therefore, it's important that we prevent at all times a care gap in patients' pathway. So, pandemic or not, we have this pandemic, cancer nurses have this crucial role and can come to actions to provide cancer care at an appropriate way by telenursing or e-health platforms. So normally we all use that we're going to work in a hospital and that we use telephone line to contact the patient or email or even e-health platforms. We're starting to use them. But at that time, there was also a thing that we have to limit physical contact with our patients. So some of us could work from home, but then it was difficult to contact patients or even have consultations with patients. So what the hospital did during the pandemic was installing a system that we could use the phone and the tools from the hospital through the hospital so we can contact the patient without giving our own number or making additional costs. So why was this important? Because we have to encourage and supporting telephone follow-up. This system was also protecting the privacy of the healthcare workers because your telephone number was not visual for the patient if you were working or doing consultations from home. We're reducing the costs by eliminating additional costs, for example. It's also very clear for patients that the contact point stays the hospital and you will transfer your line through the home line to the healthcare provider, for example. So sometimes it was a little bit difficult, the system, because you had to do some additional handlings, and it was also sometimes difficult to do some administration because the different systems, you had to open different systems and put in your information, and sometimes you have to do twice the same thing. So it's sometimes more time consuming than the regular care you did. So, for example, if patients, we had a lot of telephone calls with our patients, and we described it in different categories. So if you look at the telenursing, we could divide them in some purposes of telenursing. So there was like, for example, this patient, it's great you're calling me. We did it proactively. I'm having a rash for several days and I know it's really itching badly now. But he was afraid during the Corona crisis. I didn't dare to come to the hospital. What if I get an infection? So this patient was afraid to get an infection because he heard he was immune compromised. But he had a rash and he did know he had to call in. But he was more afraid for COVID than for his rash. So at that point, I think what we can do by telephone support is like, this is a clinical support thing, as asking patients to take some photograph, and it's also very important that there's some additional things. But this could work, but this is also that could go wrong, because sometimes people or elderly people can't handle this or use the photograph, for example, or the photograph is a bad quality, you can't see anything. But if you get any photographs in, you can see it and you can send it, for example, to the dermatology department so they can advise it. Also, our hospital has a really great system to put in these photographs in the patient electronic system. And so you can do follow-up by phone, asking your patients to do some photos every day, for example, so we can follow it easily. So it's very important that we can do a telephone assessment together with this photograph, and in this way we can do clinical follow-up and support for our patients. So another patient says like, hi, thanks for calling me. Please, can you tell me if Corona is dangerous for me? I really don't know what I can do more at this moment. A lot of our patients, especially on hematology, have a lot of rules for protecting them from infections. And sometimes they were overwhelmed by the news and all this new additional measurements from out of the media, for example, and they didn't really know what they have to do. But a lot of these rules were already implemented for them. So it was at that moment that we have to give them some educational support by phone and reassure them that they're already doing it very good if they're following the rules for good infection prevention. You could send them by email, for example, some additional information leaflets, and then have another call to go over them and discuss them together with them. That's very important because in this way you can reduce stress and anxiety with your patients at that moment. It reassures them that they are already doing very well and that if they're following like infection prevention rules, they can prevent a COVID infection, for example. Also, the caregivers are not spared. This was a patient. Hello, I speak with the caregiver, the husband in this case. Things are not going well at the moment. It's so difficult to deal with the whole situation. The illness and now Corona, I also don't know what to do anymore. At this point, we got a lot of these telephone calls where people were very anxious and stressed, but also the caregivers or partners or family members that it were difficult to cope with the whole situation with the pandemic and then also the cancer care. So telephone support and telenursing could provide good psychosocial support, and it's very important here also. And sometimes it's more difficult for this active listening to patients by telephone. But in a way, it's possible to structure things for patients and so provide the psychosocial support and reassure them so that stress and anxiety is declining. In this way, it's also very important to plan any follow-up telephone calls or refer to specialists to support them during this period if they're having difficulties. Another patient said, I'm so happy that you are contacting me. I was afraid to call because you are so busy. I'm out of medication and I didn't dare to call only for a prescription. So by the news and the media, a lot of patients told me that they were afraid to call in because they said in the media or by some media channels that you can only call in to medical services if you have any signs of COVID. So I don't really know if this was the right message. Of course, it's a message that you have to call in for if there's something going on, but also for other patients, it's very important if something is happening or they're out of prescriptions and they can't follow up their medication, it's important to take contact again to your services. So it was very important also providing that administrative support and refer to specialist care if things are happening. Because in this way, if patients are stopping medication because they don't have any medication prescription, you're creating a care gap. And this can have effects afterwards and have some impact in their overall outcome, for example. So after May, we decided to look into the numbers in our hospital. And these are specifically the numbers of the cancer center with the cancer nurses consultant and clinical nurse specialists of the cancer centers. So we looked at the numbers and compared them by the same period previous year in 2019. And we see that all physically attendance and consultations were declining. We saw the biggest one was of course the nurse-led consultations that we did, that we stopped for some time or for some patient groups. Also the visits on the wards and on the outpatient clinic were declining. Patients' visits on radiology were constant a little bit, but that's because of radiotherapy is always going through. But if you looked at the electronic contacts by email, for example, telephone support, and there were some contacts that were not defined, that we see that we there was a decrease, there was an increase of a massive increase of telephone support. And if you compare them together, you see that we had a minus of 28% in physical contact, but then we had the same number that we did in a telephone triage and even electronic contact by email and e-health. At this point, because of the registration, the specific registration system is a little bit difficult at some time, and it's not going in depth in what tool you used. I think this is an under registration of, for example, electronic contact. Sometimes you're sending a mail to a patient and you don't register it. So this is an under registration, definitely. But I think we have to do better, and at some point we can take with us that we have to align the system in the future, that we do a better administration so we can look at the numbers in a better way in the future. So there were also barriers of telenursing and e-health. I think infrastructure, even the hospital installed this, sometimes it was difficult. It's not always in the hospital of the healthcare provider that the infrastructure is not okay, but sometimes the patients doesn't have any good infrastructure. They don't have any good internet connection or telephone line. But also the regulations, think about the GDPR. Can we always use it or send some information to the patient or use this information? Did he have to give his informed consent to do this? So sometimes this was difficult. Even if you don't have any contact details at front of patients, that's very difficult to provide the appropriate care afterwards then. But also, for example, like the electronic patient file, where you have to register everything, this was not restructured to all e-health or telenursing applications. So in the future, if we're developing new ones, it should be incorporated that everything working aligned to each other. Also thinking about the costs, I think, by declining physical contacts and consultations in the hospital, we saw that a lot of hospitals have their income was declining. So, and the costs are going up because we have to take extra prevention measurements, install extra infrastructures. This costs a lot. So we have to think about it, how we going to manage in the future this, and maybe bring it to a break-even situation so we can provide good care without going in the red numbers. There is also a need for protocols. I think in the future it was difficult, and in the future we need this protocol, sorry. At this moment, we don't have any standards or protocol that support us in telephone triage. So it could be that all services working on a different way, and that could be confusing for patients, but it could be also like misformed the numbers and the details, and could be difficult to follow up if it's follow-up done by different persons, for example. Also, user access to e-health services. As nurses, we don't have any medical registration number, and a lot of e-health systems are working with this medical registration number. So, for example, in e-health platforms, if we want to look at blood work for a patient, we can't look at these numbers because we don't have any medical registration number, and we are not allowed to see the data at that point. So what are the next steps? I think the numbers were great to compare and to see that we changed the services to telephone follow-up and e-health services, but we need in-depth evaluation on the content of the nurse-led phone calls. What was the content, and can we categorize it? And can we see what we did well or what we didn't do good? So we need also aligning the hospital patient records with the phone and the e-health systems. We need to think about reimbursement of telenursing and e-health. So we have an income and we can provide in innovative systems, for example, for the future. We definitely need standard procedures and protocols, so we're all working on the same way, and it's very good to do a multidisciplinary follow-up in the same way to each other, and the communication is key here. So we communicate the same thing to our patients, and patients know what they have to communicate to the healthcare providers, for example. And we definitely need licenses for telenursing and e-health platforms that nurse consultants and nurses can view at the systems and can look to the data and doesn't have to do extra steps or to get data and to search and to help the patient at that moment. So I think telemedicine and e-health tools could provide cancer patients and caregivers a safe way to continue to receive nurse-led cancer care support, and especially during pandemic when everybody has to prevent physical contact. Ongoing development and aligning of telenursing and e-health technologies for cancer nurses-led services is definitely needed. We have to work on this because we need it in the future, and it's finding the balance between face-to-face contacts and using these new technologies to support and provide better care. So we need more protocols and license for telenursing and e-health. And I think, to conclude, I think that telemedicine and e-health tools could provide us a safe way to continue cancer care in the future, but not all care can be replaced. We will still need safe face-to-face consultations where crucial observations and advanced psychosocial support need to be provided for people with cancer and their caregivers to maximize their overall health outcome. It's all about finding the balance in the future and be prepared if we have a second wave, for example, that we can go on with good quality cancer care. Thank you very much.
So, hello everybody. I'm very pleased to participate to this satellite symposium on COVID-19, and I will present you now for the next 20 minutes oncology nurses' experiences in German and French-speaking Switzerland during COVID-19 pandemic. So I have disclosures that I want to share with you. As you all know, at the outbreak of COVID-19, healthcare providers were forced to adapt the clinical practice routines. And in Switzerland, oncology care had rapidly been adjusted following national and international recommendation and guidelines. So I put here one of the very important resources that ESMO provided since the beginning and that are regularly updated for cancer patient management during COVID-19 pandemic, but also in the nursing community. We had ISNCC that in early April published a position statement regarding the protection of patients, but also of cancer nurses during COVID-19 pandemic. Oncology Nursing Society also very early started to set up a website with specific resources that are general, but also include then more specific themes that can be looked up with a lot of different links that are provided. And EONS also was very active in sharing expertise and knowledge in videos, but also in participating to webinars that were held on an international level. So we thought in Switzerland that we might need to also provide some support to nurses, but there was another reason why we thought that webinars would be needed in Switzerland. Recently, there was a publication in Onc Nursing News that summarized the challenges related to COVID-19 for oncology nurses, and they explained this by the escalation of the intensity of being an oncology nurse. So what they summarize is that oncology nurses, as many other nurses, were worried about own health and exposure to risk of own families. They experience longer working hours, reduction in staff, and this goes with concern for patient safety. They care for people without proper protective equipment, and they are challenged by the basic principles of oncology nursing, like beliefs on hands-on care, human touch, and close human connection. And we know that all these challenges can increase the risk of burnout and compassion fatigue. in nurses. So we thought providing a platform of exchange, providing a platform where we can learn from each other and also share our experiences might contribute in the risk reduction for oncology nurses. So the Swiss Oncology Nursing Society and the Swiss Academic Society for Oncology Nursing jointly organized 2 webinars with French and German-speaking nurses, and we really had the main aim to share experiences during the outbreak. Specific aims were understanding the needs of oncology nurses in Switzerland, providing an overview of the current evidence, sharing best practice models, but also community building. So the first series of webinars were organized with 14 nursing experts and managers from different kinds of settings, outpatient settings, hospitalized settings, rehabilitation, and the community. And they were held in April and May 2020. Discussions were organized along 4 questions: how changed COVID-19 oncology nursing practice? What tools do nurses need to support patients? What would nurses additionally need? And which further supporting tools and guidelines and actions would be needed? When sharing their experiences, we try to summarize the challenges that nurses shared in these webinars together. One of the challenges were remote consultation for SARS-CoV-2 negative and positive patients, and also the lack of reimbursement policies. There was also a mention of uncertainty about the availability and application of personal protection equipment for nurses in all cancer settings, the lack of personal protection equipment for patients and their relatives, moral distress related to visiting restrictions, and the need for rapidly updated guidelines regarding PPE for nurses and other healthcare workers, remote consultation, and person and family-centered care. So we decided to organize a second series of webinars to take up these challenges. And since nurses discussed a lot along the questions related to remote consultation, we decided to focus in a second series of webinars on remote consultation. So that time we could win 12 specialized oncology nurses and an oncologist from different kinds of settings, again, from French and German-speaking parts again, and these webinars were held in June 2020. They shared their experiences on the current evidence of teleconsultations, the models and tools that were used for remote consultation, the facilitating factors to provide such consultations, but also the barriers to provide such consultations. So in the next few slides, I would like to share with you, because I think this was very precious for our colleagues in Switzerland, and we thought it might be also very interesting on a European level, because one of my doctoral students summarized very nicely an overview on telemedicine that was specifically focusing on telemedicine in oncology during COVID-19. So globally, the argument why to use telemedicine, the WHO already in spring recommended to strengthen and establish online and other telemedicine platforms to provide direct clinical services and clinical decision support. And we can also see this in the growing investment in health technologies in the United States as an example. So before COVID, compared to April 2020, there was an increase. So the investment in health technology nearly doubled regarding to the investment in other domains. So it seems that this recommendation has been taken up. Of course, the benefits that we believe these tools could bring is the accessibility for patients. They do not have to come into the hospitals or clinics. It's a more rapid healthcare provision, and it might be more efficient also economically. And it allows us to respect the preventive measures of the pandemic. So I would like to show you now the different types of services for oncology patients and the opportunities for nursing care. Globally, there is the umbrella term of telesurveillance that includes teleconsultation, telephone triage, that provides information to patients, but also management and referral of patients to health services. And I will show you 2 examples of this that were adapted due to COVID-19. And there are also digital devices that can be used for remote symptom monitoring, and again for management and referral of patients to health service. I would like to introduce you to a model that was developed in France by colleagues from Gustave Roussy. So if we look at the telephone triage, there is the 24-hour triage tool that was developed by EONS, and we are currently in a phase of translating this to French language as well. And it works that the responder assesses patient symptoms and their severities and translates it into 3 types of alert: green, amber, and red, to differentiate the degree of care that this patient might need immediately. So during COVID-19, there were recommendations that were changed. So live face-to-face assessment and forwarding to emergency services should be avoided whenever possible. And the medical and specialist assessment through telephone or video conferences should be favored as much as possible. If we look at the algorithms that this triage tool provides, they give some selection criteria at the beginning and then guide through, and I will not go into the details of this, regarding the COVID-19 symptoms that are present or not. There will be a different follow-up, and regarding this initial risk criteria that were posed, this algorithm will be applied in a different way. So this is how the triage tool has been adopted. Then there is also a triage tool that was initially developed by EONS. There's also this publication that might be known, and it is recommended also by EONS as a specific triage guide for COVID-19 patients. Again, I do not have the time to go into detailed presentation of this, but you can see that they have different triage guidelines for patients that are exposed or COVID-19 positive patients or suspect cases, and they give very concrete and clear guidelines for the triage and the conversation or consultation of patients. All this is available. We will not go into the details of this, but I just wanted to raise your awareness about the availability of this. Third example that I would like to share with you is this mobile application that has been developed at Gustave Roussy, initially for patients that receive oral treatment, but during COVID-19 it was adapted to be the Capri-COVID program. And again, there is an algorithm that is already distinguishing patients that have access to a smartphone or not. And then the nurses, who are called the nurse navigators, will guide the patient or by telephone or with this application, and according to the different symptoms that the patient expressed, via telephone or via mobile application, the nurse navigator will make a triage and guide the patient to the best care option he might need or might need to receive. So we discussed these models. We discussed also the evidence of these models. People working with these models were present also in the webinar, and above these different discussions of different teleconsultation models, there were also other results that were highlighted. So teleconsultations seem to be here to stay, was one of the frequently made comments of the participants of the webinar, and they also proved that nationally, if we compare the different language regions, but also if we compare the different organizations or cancer care institutions, there were very different ways of teleconsultations were conducted, how they were documented, how they were built across different cantons. So the overall conclusion was that we really need a national level guidance urgently to standardize practice around these novel solutions. So the conclusion of the webinars from the perspective of all my colleagues that I also want to once again thank for their investment in these webinars, it has made clear that the communication remains the best weapon at the nurse's disposal to face the unprecedented situation, allowing us to identify the needs of patients and professionals and reveal solutions propelled by our peers' ingenuity and hard work. We also believe that these webinars are incredibly useful to further the development of a concerted, more effective and comprehensive effort to meet the challenges of tomorrow. So we invite you to stay tuned for an upcoming webinar, if you speak French or German, and how we are preparing for the challenges of the second wave. It was a great pleasure, and I hope you have a lot of questions that we will be able to answer in our session. Please keep in mind that there will be a live session following the presentations that were pre-recorded, but all the speakers will be present during a live Q&A session at the end of the session. So for 30 minutes, you can write us your question. You can already write them right now, and you can then attend to this Q&A session to follow the discussion. Thank you so much for your attention, and again, it's really a big honor and pleasure to be here with you today. Thanks.
So my name is Matt Fowler. I'm a nurse consultant for oncology and haematology at the University Hospitals Birmingham NHS Foundation Trust. And today I'm going to be talking to you about digital health and COVID-19. Just to give an overview of the things I'm going to be talking about today, I'll do a little bit of a background with regards to what I do as a cancer nurse in the United Kingdom, so that fits in with how I've had to adapt my role, as well as a lot of my colleagues have had to adapt their roles during COVID-19. I want to talk a little bit about the landscape pre-COVID-19 in order to try and feed into how things have changed over the last few months, because they've certainly changed quite dramatically. Particularly looking at digital health during COVID-19 with regards to use of IT systems, and particularly focusing the biggest part of digital health for me has been the use of the telephone that I wouldn't have used much before when consulting patients. Looking at some of the lessons that we've learned during the last few months, some positives as well as some things that we definitely need to improve in the future. And that will lead me on to my final element of my presentation, where I look at the future for digital health in cancer care, particularly from a nursing perspective as well. So if I start off just by giving a little bit of background to my role and my journey to where I am now. I've been a cancer nurse for over 22 years now, and I work across both haematology and oncology, so I work in both specialties, including bone marrow transplantation. I train in Birmingham in the West Midlands, and I completed all of my specialist cancer training at the Royal Marsden Hospital in London, and that was about 20 years ago. I worked for approximately 5 years as a senior charge nurse at Queen Elizabeth Hospital in Birmingham, covering both oncology and a large level 4 JC accredited bone marrow transplant unit as well. I then decided that I wanted to move into advanced practice, so I completed my non-medical prescriber training, undertook a Master's in Sciences for Cancer Nursing, and then actually decided that I really wanted to progress in advanced practice. So I did a postgraduate certificate in advanced clinical practice at Warwick Medical School. And I've been working in advanced practice for the last 9 years now. I am embarking on my PhD journey, and I say embarking, I'm actually 2 years in now. So slowly getting my way through that as well. It's a bit of a challenge working academically, trying to do academic work and working clinically, but I get there, I think. My particular interests outside of work are Greek, tennis. I play as much as I possibly can, see my family and friends. And I'm also an honorary lecturer at Bethlehem University in Palestine. My other commitments, I am a very proud member of the EONS Advocacy Working Group. I'm also recently joined the EBMT Acute Leukemia Working Party Group as well as a nurse expert in the field. And I write court reports for when things don't go so well. So I'll actually represent cases in the NHS whereby I'll either be representing the NHS or indeed a claimant. I teach at Warwick Medical School, and I also work part-time in a GP surgery as well, which gives me a very broad overview of cancer care because I see it pre-hospital as well as during the hospital. So the kind of things that I do, and pretty much I still do the majority of these things even during COVID. It's just the way that I had to do things obviously altered. So I do a bone marrow biopsy list on a Monday morning and do lumbar punctures on a Monday afternoon. I then run specific cancer care clinics whereby I see patients with urological cancers and gynae-oncology cancers, whereby I see the patient, assess them, prescribe chemotherapy, request investigations, and switch treatments sometimes if things aren't going so well, and predominantly perform a good thorough nursing toxicity assessment. On a Wednesday morning, I insert PICC lines, portacaths, remove Hickman lines, and that's pretty much my vascular access list. I then work in a GP surgery on a Wednesday afternoon. On a Thursday morning, I do a colorectal oncology clinic, pretty much mirroring the things that I talked about earlier on the week during the urology and the gynecology clinic. I then actually do manage to get some admin time on a Thursday afternoon where I try and develop practice, look at research, education. And then on a Friday is my bone marrow transplant clinic day. So I'm purely looking after patients, both pre and post bone marrow transplant. I'm also on the on-call plasma exchange rota, so that's 24 hours a day. I manage all of the non-malignant haematology services in Guernsey, which is in the Channel Islands, near to France, and I manage most of that remotely, which did actually put me in good stead for having to do telephone clinics, because it's not something that I'd particularly done before. I manage all of the patients with hemochromatosis in Guernsey from Birmingham. I've got a very keen interest in low-risk febrile neutropenia, and this is the subject of my PhD. And I still continue to practice as a chemotherapy nurse as well. And I think that's very, very important that as a senior nurse, I'm still seen to actually give chemotherapy and still what happens very much on the shop floor. So if I think about what was the landscape like pre-COVID-19, all of our clinics for patients were face-to-face. We did not do any telephone consultation clinics. It's something we've talked about for many, many years, but we just never seem to get round to doing it. So it's always been face-to-face clinics for patients on chemotherapy, as well as follow-up radiotherapy clinics. I see a lot of patients with prostate cancer that have finished their radiotherapy, and I'll always see them face-to-face in the clinic. Just do a quick toxicity assessment post-treatment, check the prostate-specific antigen, and then refer back to our urology teams for surveillance. I do a lot of follow-up SACT, so systemic anti-cancer treatment clinics, both chemotherapy, hormone therapy, immunotherapy, and other oral agents. And this very much is focused around the toxicity assessment of treatment, as well as response to treatment, and then prescribing necessary agents as well. See patients at the end of treatment. Now that can be the end of their adjuvant curative treatment, the end of their neoadjuvant treatment, whether that be they go on to get surgery or radiotherapy, or indeed the end of their palliative treatment, whereby we have no further chemotherapy options for patients and we refer on them for best supportive care. Do a lot of surveillance clinics whereby I'm actually monitoring patients on treatment. And obviously, unfortunately, that comes with the job that we do, breaking bad news as well. So that's always done pre-COVID on a face-to-face basis. So COVID-19 came upon us quite hard and fast in March 2020, and we had to change the way that we practiced pretty much overnight. We ceased all but essential outpatient activity. We had to stop many patients' cancer treatment where we felt that the risk of COVID was far greater than the risk of the patient's cancer. We immediately initiated telephone clinics. We started remote working as a team. So a lot of my team, I actually encouraged them to work from home. And we had to completely reconfigure our inpatient work as well. One of the biggest things we had to do was to reduce the footfall into the hospital. So that meant we had to try and avoid unnecessary phlebotomy. We had designated hot and cold areas so that patients could be streamed as high risk COVID, low risk COVID. We pretty much stopped the majority of our imaging, as well as reduce the amount of diagnostic tests that we undertake as well. So this was change on a level that in my 23 years as a nurse, I've never seen before. So it was quite daunting at the time, and still can be now to some extent. So digital health during COVID-19, by far focused around the telephone. I would love to be able to talk to you today about the innovative internet-based video conferencing that we implemented, but we couldn't. We didn't have the infrastructure to do that, and we equally didn't have the time. So we switched all of our clinics from face-to-face to telephone. We had to get laptops so that we could access all of our clinics from home. And then you've got to make sure that you've got VPN, decent internet access, and that was often a problem as well. If you've got slow internet access at home, then you can't access all of the necessary systems that you need to safely to access all of the patient records. I think one of the things I really struggled with was the fact that I've always taken part in informed consent with patients on a face-to-face basis. We were now finding ourselves in a situation where we were taking verbal consent for treatment over the telephone and just having to document the fact that we had gained verbal consent for the chemotherapy regimen or hormone regimen that we were going to be giving. All of our new patient assessments, which is key as a cancer nurse, is that it's that first initial consultation where you meet with the patient, you meet with their loved ones, and you actually get to go through all of the necessary patient education, as well as find out if they've got any gaps in their care so that you can address these. And it's so important that you can tease out issues that the patient might be having, or any issues that the loved ones might be having, and you lose that with telephone consultations. But again, we had no choice. We had to change the way that we practiced. Toxicity assessments, and I think this was probably one of the hardest things for me, is trying to garner, particularly the toxicities that we need to see, particularly the skin. There's so many of the treatments that we give. If I think about immunotherapy, tyrosine kinase inhibitors, EGFR inhibitors, those drugs can have quite devastating skin toxicities. Yet you're doing all of this over the telephone without actually being able to see the patient. And equally, we found ourselves more and more having to have some very difficult conversations over the telephone as well that we would have never have dreamt of having before, whereby we're stopping treatment or sometimes having to break bad news as well. That was a particularly challenging area for me, and I know it was for many of my colleagues as well. So if I think about the lessons that I in particular have learned, one of the most important things is that one size doesn't fit all, and you cannot assume that all cancer patients will be able to adapt to telephone clinics, and we need to think about different ways that we can actually manage a lot of these patients, and I will come on to talk about that shortly as well. One of those practical bits of advice that I would have given myself at the start of all of this would be to have used a headset. And I know this sounds really, really minor, but I found myself doing this with the telephone against my ear and then typing on a computer to try and access results. Ergonomically, this is not good for your posture, and I'd find myself at the end of the day having a particularly crooked neck. So this is one of the most important things for me, is to use a headset. Patients with hearing impairments, I had some particularly challenging telephone consultations where the patient just could not hear me. They didn't have conduction loops, and I'd find myself, and this is so bad, but I'd actually find myself almost shouting down the telephone to make myself understood. Patients that English is not their first language. I work in a very diverse area of an inner city hospital, and we have patients from a huge different background that English is not their first language. So again, I found this particularly challenging, not only the language barrier, but equally the issues surrounding the toxicity assessment as well. We're fortunate enough to have a language line that we could actually dial in so that all three parties, myself, the patient and the interpreter, could all do a telephone consultation at the same time. But you actually need to pre-plan that. You can't just do it at the time. So again, that takes organisation. Patients with dementia, again, I've looked after a few patients with dementia that have cancer as well during COVID. And for some patients with dementia, especially in the early stages, it's not too difficult to actually have those telephone consultations, especially if you've got a family member there. But when you've got patients that are on treatment that maybe live in aged care facilities, it's not the right fit. And I think, we do need to think about these types of things, because these were not things that I particularly considered at the start. Virtual toxicity assessments, what I found my way around that was to actually get the nursing staff to actually see the patient when they came in for their treatment, so that they could actually physically see the patient, because I just got a feeling sometimes, and that's something that we get as nurses, we get a feeling that something's not quite right, but it's difficult to garner that over the telephone, whereas you can use all your non-verbal cues when you actually have a patient and a loved one that's face to face with you. Communication was key, particularly with our primary care colleagues, because again, a lot at the time, a lot of GPs weren't able to see the patients that they wanted to be able to. So we had to make sure that we were communicating effectively with our colleagues in primary care, as well as actually with the patient itself. And this is one thing that I've started doing, is I've actually started writing to the patient and copying in the general practitioner and other specialties, so that actually, for me, keeps the patient right at the centre of it. And you can kind of reflect on all the things that you've said during a consultation. It then goes down into black and white for your patient. And again, if they've got any concerns, they can bring that up during the next consultation. It's really important that we liaise with their significant others as well. The amount of consultations I did where there would be 3 or 4 people, as well as the patient, in the background, actually asking various questions and trying to manage that, being assertive but equally being kind and empathic and understanding, could be quite a challenge at times. But I think I definitely managed to garner that one. Breaking bad news for me was by far one of the most difficult things I've had to do over the telephone, and it's not something I think we should be looking into at all. I think at the time we genuinely could not bring patients into hospital due to particularly in the UK, the hospital I worked in, we had large volumes of patients in with COVID-19. So we did not want to be bringing patients into hospital that were already immunocompromised. And having to break that bad news over the telephone was awful, and has definitely had an impact on myself as well as my colleagues as well. I think allotted telephone appointments, as much as I would try and stick to the allotted time that the patient was booked in for their telephone consultation, one of the problems of not actually having the patient in the hospital was that you're actually a lot more accessible to other people. So I would constantly be getting interruptions from other nursing staff, from my medical colleagues, and rightly so, because they needed some help with something. And if you've got somebody that's acutely unwell that you need to prioritise, it's difficult to actually let the patient know that you're meant to be having the telephone consultation with, that you're going to be a little bit late. So that led to quite a few apologies on my behalf. And equally, I'd follow that up in the letter as well, that I'd again just put in that I'm really, really sorry I was unable to talk to you at the allotted time. Dedicated administrative support has been key for me, and I'm very, very fortunate to work with the most amazing admin team, and they were key for me at making sure that all appointments were organised, because that is one of the biggest things for patients. Is they're most concerned about is, when's their next appointment, what time do they need to go for their chemotherapy, what day do they need to get their blood test done. That's, as clinicians conducting telephone consultations, that's not necessarily your priority. So by having that dedicated administrative support is key to actually say, right, I'm going to get in touch with somebody else and they're going to call you and they'll go through all the fine details that are important to patients. So if I think about some of the positive aspects of this, and there have been as well, I think the rapid rate of the change in practice was, for me, working in the NHS, where we used to working with a lot of bureaucracy and red tape. This was amazing. We changed the way that we practiced overnight. And that for me was, you know, that was a real breath of fresh air to actually see, well, actually, we can do things differently. So we will. As I say, a lot of the red tape had gone that we were used to working with. If I think about senior telephone triage, that has been particularly key, whereby we actually have patients that call up unwell. And we changed it so that we've got actually really senior clinicians triaging these patients over the telephone. Because if we didn't need to bring them into hospital, we wouldn't. And we'd actually take a more risky approach to actually saying, right, do you know what? Yes, I know there's a temperature. The chance of you being neutropenic at the moment, it's highly unlikely. So we want you to try and stay at home. We're going to arrange for you to get some antibiotics delivered to your house. And you just have to do a lot of safety netting to try and keep the patient safe. And that did prove quite challenging at times, but equally, I've got quite a lot of data that's proven that we as a very small team managed to keep a lot of patients out of hospital and do so safely as well. Increase patient ownership of their health. For so many of the medications that we give, we need patients to check their blood pressure, dipstick their urine for any signs of protein. And we actually just started teaching patients to do this themselves. We've got ambulatory blood pressure monitors. We could send them home with urine analysis dipstick. So again, we reduced the footfall of the patients having to come back to hospital, and equally empowered the patient to take part of their, to take real part in their care as well. We had to prioritise our vulnerable patients remaining at home, because for immunocompromised patients to be coming into hospital when you've got wards and wards full of patients with COVID, this was not the right thing to be doing. So we had to try and see what we could do for patients at home. So one of the things we have set up is we've got some healthcare support workers that actually go out to patients' houses, to cancer patients. They do all of their routine blood tests. We routinely swab for COVID now for all of our patients prior to each cycle of treatment. They will do all of this in the home, so as to try and reduce the vulnerable patients that we have actually coming into hospital. And I think I touched upon this a little bit earlier, but we had to upskill our chemotherapy nurses because we were reliant on telephone consultations to assess toxicities. We really needed our chemotherapy nurses to have up-to-date knowledge and skills to actually do a very, very detailed toxicity assessment prior to them receiving their treatment. I think finally, if I think about how I see the future for digital healthcare in cancer going, one of the key things for me is app technology. There's a small group of patients that I look after with myelofibrosis that there's an app that they use they input all of their symptoms, they input all of their blood results as well as their medication doses, and I can definitely see this is definitely going to be the way forward. And equally, I do not feel that we should exclude our older patients from this either, because so many of the older cancer patients that I look after, they actually embrace smartphone technology. So again, I think we need to engage with tech in order to make sure that we do have apps available for our patients. I really need to look into video consultation. From a very selfish point of view, I need to be able to see my patients when I'm having a consultation with them. And again, there are ways and means around this. So a lot of it boils down to some of the governance, making sure that we've got secure platforms. So we need to think about confidentiality for our patients when we're having consultations with them. Electronic prescribing for me is key. And again, I work in an organisation where we've still not got, in the department I work in, we still prescribe everything on paper. So if you're doing a clinic from home remotely, so much of it's quite fragmented because so much of the work you do is done using IT systems and telephone, but then you still need to print off a paper prescription and get that into the hospital. So again, in the future, I'm certainly hopeful that that won't be the case. think we really need to look at electronic care plans for patients so that they have actually got access to all of their own records. And I say this to every cancer patient I look after, but these records, they're their records. It relates to their care. This, we are very privileged to do the role that we do, but we should be allowing our cancer patients to access all of their care records. So that actually, as again, it's about empowering our cancer patients. And I feel this is very strong and this is very important. Training and education is key on so many different levels. We've not really had any formal training on how to do telephone consultations, on what skills we need to make sure that if we are going to continue doing, things like informed consent over the telephone, then, what governance have we got in place to make sure that that is robust? And finally, I do have to finish with this point, and that is that face-to-face consultations still have a place in cancer care. I stand by when we have to break bad news to cancer patients, I genuinely do not believe this should be over the telephone, unless it really has to be if the patient can't get into the hospital. And I think there are still certain consultations where there might be issues where you genuinely need to see that patient to see how things are going. If you're genuinely concerned, then for me, that should be face-to-face. So I've got my NHS email address there, as well as my Twitter handle. I'd like to thank you for affording me this opportunity to do this presentation today, and I'm always more than happy to be contacted. Thank you.